first test that we're going to do is a central posterior anterior. The CPA is me taking my fingers and the thumb tips and actually feeling on the spinous processes and pushing downward. And I will work my way down from C2 all the way down to the thoracic region. Let's just discuss why I'm doing this for starters. Because a lot of people struggle with this. They say, what does this do? It doesn't follow the movement pattern of the facets. You're just pressing on tissue. What is it telling you? Well, it tells me this. There's quite a few studies that have shown that a central posterior anterior, a CPA, and its brother, the unilateral posterior anterior, which I'm going to do in a minute, are very strong neurophysiological techniques. And we mentioned earlier that manual therapy is all about neurophysiological changes. It's so much more compelling than biomedical or biomechanical changes. So what I'm doing is providing an impulse of neurophysiological bombardment in that cervical region. I'm seeing if movement applied with a passive accessory motion actually changes the pain and or movement strategy of the patient when we send them back up. So I address the patient from the top side. I'll use my tip-to-tip grip. I'll lean over the patient and apply a very gentle downward push into the spinous processes. In most cases, I only push until my thumb nails actually blanch. Then I know that I'm not pushing too hard for the patient. I think a big mistake that people make is that they push too hard initially, and they don't really feel anything because they're plowing through the patient's tissue. I also think it makes the patient quite uncomfortable. So nice and easy, an easy glide, passively push, work all the way down on the spinous processes, communicating with the patient the whole time. A lot of people ask me too, don't you also feel for which segment feels stiff and which doesn't? That is less of a concern of mine. I'm more concerned about reproducing the concordant or comparable signs of the patient. That's going to give me more information. And then I'll actually repeat the motions, repeat the dosages to see if it helps the patient as we continue that examination. A unilateral posterior anterior involves pushing on the articular pillars or the facets, and we talked about those earlier in the anatomy module. They are just lateral to the spinous processes, but they're actually palpated underneath tissue. So in order to do this correctly, you have to reach with one thumb and pull the paraspinal musculature medially out of the way. So I'll pull her tissue out of the way. I'll put my thumb in on the first facet, and I'll actually apply a downward force. That first facet that we can feel is a C2-3 facet. It's the same nature of the beast that we've been talking about. I'm looking for a reproduction of the patient's symptoms. I'm looking for their concordant or comparable sign. If I identify that concordant and comparable sign, then I'll repeat these movements to see if it makes a difference in the patient's condition. If it does, then we know that we might have a potential manual therapy technique.